Hello, I'm Lisa Ling, and welcome to The Road to a Vaccine, a weekly exploration of the COVID-19 crisis and the global community's efforts to develop a vaccine against the disease. What makes this show unique is that we have access to the world's preeminent scientists and healthcare experts, and you have the opportunity to ask questions of them live every week. So if you do have questions, feel free to put them in the comment section, and we will try to get to as many as we can throughout the show. Now, as of this week, there are 5.5 million total confirmed COVID cases and over 340,000 global deaths. The numbers continue to rise, yet there have also been 2.2 million global recoveries. The recoveries, however, beg the question, what does that actually mean? Are those people safe from being reinfected, and are we safe to be around them? As many places around the world and US states start to open up, there are so many new questions and concerns about what is safe and what a return to normal looks like. Our guest today can help shed some light on this. We'll talk to J&J's Chief Scientific Officer, Dr. Paul Stoffels. He's been on the show before, but today he will come from the lab in Beersa, Belgium, with an update on his team's progress in their COVID vaccine development. Then global health leader, Dr. Jonathan Quick from the Rockefeller Foundation places his bet on testing. And something you definitely don't want to miss, a beautiful story about an artist who was so inspired. She created the most incredible mural. The first time I saw it, I got very, very emotional, and I can't wait for you to see it. But first, Dr. Mark McClellan is the former commissioner of the FDA and director of the Margolis Center for Health Policy at Duke University. He's a key thought leader advising the U.S. administration on what a return to normal looks like. Dr. McClellan, thank you so much for being with us. Now, as we all know, the U.S. is about to embark on a very grim milestone, 100,000 deaths attributed to COVID-19. Yet there are many people here who just don't believe in the virus's lethality and compare it to flu deaths or other diseases. And sadly, the disease has become quite polarized by so many. So as someone who has spent his career studying diseases, what is your expert opinion on how dangerous COVID-19 actually is?
Lisa, first of all, it's good to be with such a unique program, and I appreciate the opportunity to join you. COVID-19 is a real public health threat, unlike any that we've faced in a long time, a century or more. I know that people would like to be past this, would like to think it's just a flu, that they don't have to do anything differently. But fortunately, we see a lot of public responses, a lot of responses from policy leaders to how we can actually live with this virus and go about more normal activities. You know, we just went through Memorial Day weekend in the United States, which is normally a special time. It's the unofficial start of summer. It's a good time to get out and relax, but it's also a time to remember everyone who's sacrificed for the country. And this year was different because it's not just our military leaders and people who have given their lives to protect the United States and the things that the country stands for, but also our health professionals who have been so disrupted by this pandemic, and then, as you said, close to 100,000 Americans who have died because of it. I know some people think that because the fatality rate is not that high and because it mainly affects older individuals and people with chronic conditions, that they're somehow safe. But if you look at the flip side of that, the fact that the mortality rate probably is pretty low overall, the flip side is that the rate of transmission of this virus is much higher than a typical flu. And also, people can often spread the virus when they don't even have any symptoms. And that makes this a bigger public health threat. So even if you're not worried about protecting yourself all of that much, what you do has a big impact on all of those around you. And that's why the kinds of recommendations that we've made through our program at Duke and with collaborators in the U.S. around how countries can reopen safely, what the markers are to look for, what businesses can do, what individuals can do differently are so important. We can reopen, but we have to take the pandemic very, very seriously.
Exactly, and there's still so much that is even unknown about this virus. So to discount it, to me, just seems not be the smartest thing to do. Now, we're all coming to grips with the reality that we're going to be living with this virus for a while. So as more countries and US states try to balance public health with a return to normalcy, what would you say reopening should look like? I've heard you talk about super spreader activities. What do you mean by that?
Well, what we want to avoid is as we've just been discussing, the many circumstances, if we don't make significant modifications, when spread can happen really quickly. And there's several things to keep in mind to avoid that. One is proximity, how close you are to other individuals or how close people are together where they might spread. The other is the time in which people are together. Shorter durations better than longer duration. And the third is the type of activity involved. And there are activities like singing, even talking for some period of time, touching similar surfaces or objects in commonly used areas if they're not disinfected and cleaned regularly. All of these kinds of things can contribute to spread. So what reopening should be about is taking steps to prevent those things from happening and making sure it's occurring in a context where if there is an outbreak, it can be contained and it won't overwhelm local healthcare capabilities. So as we move beyond just the staying in place in the United States and other countries, which was essential and which worked to head off peaks in cases and flatten the curve, as people say, now we're moving into not going back to normal, not the old normal at all, but to more limited versions of keeping the virus from spreading that are not nearly as disruptive. That means businesses need to do things different as they reopen. There'll be more space between individuals for offices, lots more people continuing to work from home where that's possible. For schools, maybe shifts with fewer students in the classroom and students keeping in smaller groups, not going to a lunchroom and maybe not interacting so much between classes and things like that. So businesses are going to be different. Some we think are not ready to reopen at all now, big events with crowds, for example. But what's really important is what people do. And as you said earlier, some people are not taking this as serious as we'd like. But in the U.S. and I think in other countries as well, we've seen some big changes in behavior. Most people paid attention when their governments asked them to stay home, and it worked. And we hope as we're going forward that people will continue to pay attention to the guidance that's out there, keeping 6 feet or a couple of meters away from others wherever possible, using masks to reduce the likelihood of spreading if you happen to be asymptomatic, and probably protecting yourself some too. Washing hands or using hand sanitizer frequently, not touching your face, and being careful about the common surfaces that you touch as well. So steps like that are going to be really important for success. Businesses can do it. There are important policy steps that can help make this succeed. Testing, as you're going to talk about with Dr. Quick a little bit later, is really important in all of this. But in the end, it comes down to what we all do to help slow down the spread and be able to get through this new normal successfully.
And it's so important to at least err on the side of caution, because there have been reports by the WHO that cases have spiked here in the US, in Russia, in Brazil, and India. So if this continues, given the global society that we are, is it possible that we could go backwards? And if so, how will it be safe to reopen again?
Unfortunately, it is possible, and some of the work that our group and other groups have done in the United States and elsewhere on reopening, there's several themes that come out. One is, ideally, you wouldn't reopen until you're confident that you've got the cases in your community under control. That ideally means a downward trend in cases, a big margin between the amount of hospital beds and health care that you need to care for those cases and the amount that's available. So there's plenty of surge capacity. On top of that, you need to implement this gradual process for reopening that I've just talked about, starting with activities that are relatively safe, see how those go and expand from there if there isn't a new surge. And then again, very important is being able to test, because so much spread is asymptomatic, especially in higher risk settings that we've seen in the U.S. and around the world, like nursing homes and meat packing facilities where people have to be close together for work. It's just very easy to spread unless you take extra steps to monitor who's coming in, prevent spread. And that means, again, everybody paying attention to steps like, if I have symptoms that could be COVID-19, cough, a fever, a sore throat, loss of sense of smell, things like that, stay home. And if you're working in a higher risk environment, just be aware of being extra careful about the kinds of personal steps that I talked about before. Businesses need to change, both to make it less likely for transmission to occur and to do more testing to help detect cases where there aren't symptoms.
We haven't talked about going back to the doctor and thinking about healthcare providers and how we can open up that part of society. Some of us haven't been to the doctor because hospitals have been preoccupied, or they have solely been treating COVID cases. So how safe is it for us to do things like go to routine doctor visits and have elective procedures?
Well, Lisa, as you point out, one of the biggest health consequences of COVID-19 isn't just the deaths and the hospitalizations that are occurring from the virus itself, but from all of the disruption that's occurred in people getting access to healthcare, as well as to all the other things that are really important for their health and well-being, their mental health as well. So in just about every part of the U.S. now, for people who do have urgent healthcare needs, people talk about elective services, but things like if you've got a new lump that could be cancer, if you haven't had your blood pressure checked and you have heart disease, if you've got other problems, pain, other symptoms that are serious, don't put it off. I think we're seeing changes in healthcare very much in keeping with what I was talking about before, about going more virtual, that are helping a lot of people get access to the care that they need. But if you need to go in to get a procedure done or have an MRI performed, check with your doctor, and there are generally procedures in place that make that as safe as possible. That said, so don't put things off, but also be sure to ask questions. Is this really a necessary procedure? And are there better ways that I could manage my chronic disease from home? We've seen some tremendous innovation in the last few months, building on progress over the last 20 years to move to digital health, to people being able to get conditions like heart disease or diabetes or other illnesses, back pain, managed from home or out in the community using apps and using new technology. So be sure to ask about those possibilities too. We need to encourage more healthcare that's delivered that way as well. But don't put it off.
Certainly, certainly is the way of the world now, communicating digitally as we have been. Dr. McClellan, I have a question from Tammy from Facebook. Will asymptomatic persons eventually become ill?
Some asymptomatic persons do become ill. In fact, probably the majority do. Unfortunately, there's a period of at least a few days between when you've been exposed to the virus and when you start to have symptoms, if you're one of the people going to get symptoms, where you don't know that you've got it yet. And in the last couple of those days, that's actually where it looks like a significant amount of virus transmission occurs. So even if you think you're healthy, it's important to wear a mask. It's important to wash your hands and watch what you touch, both for your own well-being and to protect your loved ones and the other people in the community around you. And there are a number of cases that will go on, perhaps 30–40%, that are not ever going to show symptoms. So that's a really challenging part of containing this virus spread.
Exactly. That's why this virus is so confounding. Now, the show is called the Road to a Vaccine. So I have to ask you, as former commissioner of the FDA, what are your thoughts on how we develop a vaccine on such an accelerated timeline? How do we ensure that it's safe? And is it possible to fully reopen without a successful vaccine?
Well, on the last question, I think even when we get a vaccine or vaccines that work, things are still going to be different for a while. They won't be available to everyone right away. We won't know for sure that the vaccine provides long-term immunity or protects everyone. So we're going to have to be cautious for a while. But no question, vaccines are the game changer and the way out of what we're having to live through with this pandemic. And that's why I think you're seeing a completely transformed approach to developing vaccines now compared to just about any pandemic I can think of before. You're going to get to talk to Paul Stoffels next, who's one of the world's leading experts on not just the science, but actually accomplishing effective vaccines for conditions like Ebola that had also been really serious threats. What I think is most different now is because of the magnitude of this pandemic, how many cases all over the world, the economic impact, the health impact, all these things that we've talked about, we're not going to cut corners on developing the vaccine, but we're going to make the process faster by turning what traditionally has been a kind of a slow and iffy linear process into a hyper-parallel one where all the key steps get done, but they get done in a much more coordinated and simultaneous way. So you first of all have to find a vaccine candidate that works, and that involves some preclinical testing and the like. But after that, there should be a very clear path where everyone, the people who are developing the vaccine, government officials, the public health agencies like the FDA in the U.S., all have a clear understanding of what needs to be shown to demonstrate that the vaccine is safe and effective, not to cut corners, but just to be clear about it. And then with that clarity in place, it's also possible to plan ahead for the very important clinical testing that needs to be done, because vaccines are going to be given to people who are relatively healthy, because it takes time to develop an immune response and show that it actually works. These are large trials that are going to take months, but by planning ahead, we can make sure we have the ability to implement these trials right as soon as the clinical vaccine compounds are ready. And we're starting to see that happen now, with several vaccines being tested around the world in clinic in the U.S. and in England, in China, and elsewhere. And that's a reflection of planning ahead for this clinical testing. And at the same time, there is an unprecedented investment in the manufacturing needed. So to do vaccine availability at scale for the globe, we need billions of doses, several hundred million in the U.S. alone. And what you're seeing in the U.S. and other countries, and through international efforts like CEPI and Gates support, is to try to build a lot of that capacity now. So there's not, again, months or years of wait time between when you know the vaccine actually works in those clinical studies and when it can be made fairly widely available, at least to high-risk individuals. And that's why people like Tony Fauci are saying that if things go well, if all of these parallel steps work out, we could have vaccines available, at least some vaccine doses available for high-risk individuals by later this year, and certainly a lot of opportunities for 2021, including with the J&J effort that you're going to hear more about next. I think the only other thing I'd add here is that this is also a parallel process, and it's not a race with one winner. The idea is to support all of the vaccine candidates that show real promise, get them into clinical testing as fast as possible, support as much manufacturing as possible. We may end up throwing away hundreds of millions of doses, but if we do this together in a coordinated way, there's a very good chance that we may have multiple vaccines that are at least fairly effective much, much sooner than has ever been possible before.
Well, let's hope that is the case. Dr. Mark McClellan, thank you so much for your expert insights, and also thank you for introducing our next segment to the audience. Now, in case you are just joining us, this is The Road to a Vaccine, a weekly exploration of the COVID-19 crisis and the global community's efforts to develop a vaccine against the disease. Continue to put your questions in the comment section, and we'll try to answer as many as we can during the show. As Dr. McClellan said, our next segment is Vaccines 101, and this is where we learn the basics from scientists who create vaccines. Today, we have Dr. Paul Stoffels, J&J's Chief Scientific Officer, with us from Beersa. Dr. Stoffels oversees the team of J&J scientists working around the clock to develop a vaccine. Dr. Stoffels, it's so nice to see you again. It's been 4 weeks since you and I last spoke. So how has the COVID-19 crisis changed in the past month? And do we know more about the virus that we didn't know a month ago? And have there been any developments with the vaccine in the past few weeks that you can tell us about?
Well, I think the most important thing we learned from the epidemiology is that the actions taken by governments on stay in place from social distancing have worked. So you can already take action before a vaccine is there in order to make sure that we flatten the curve, we don't overburden the hospitals. And it worked in many countries, so that step by step, the measures can be released on how to go back, open up manufacturing plants, open up shops, open up maybe restaurants soon. So, but all with very cautious measures to make sure that distancing, social distancing, and you preserve health with like that. So we learned already that part. From a scientific perspective, we learned, I think, the group published last week 2 science papers, and what we learned is in the one experiment with non-human primates, we learned that when we infect animals, we can make them sick. They get sick, they cure, and when we then try to infect them again a month later, we can't get them infected a second time. And if you look at the neutralizing antibodies and the immune response they have created within that first disease, it is very comforting now that we see that we can't challenge them a second time. You can challenge them, but very quickly they mount an immune response and protect themselves against it. So that's an animal experiment proving that most probably, if you get infected, there is a way that you can be protected for longer term. The second thing is that animal
Well, can we conclude that if it works in those animals, in the monkeys, that it will work in humans?
No, you can't conclude that. We still have to learn that in humans too, but it's always a good predictor that if it works in animals, which are not that very different in genetic makeup than us, if you can protect them and their immune system defends, then we learn from many other vaccine experiments that it's very predictive for what's happening in humans. So that's a good step. The second thing what we were able to do, or Dan Baruch and his team was able to do, is take prototypes vaccines from what we are working on, get them into animals, vaccinate them, and then challenge. And what you see is that you can challenge, and the animals are protected with prototype vaccines. But what's very important is that the type of DNA you use from the spike, the piece of the spike you chose, is very important to have more or less immunogenicity in a non-human primate. And that's what I was explaining last time. We did 12 vaccines. We first tested the DNA fragments, then now testing the vectors to show which part of the spike is the most immunogenic and protects best. So if you do that and you then challenge the animals, then you can see that the protection is related to the quantity of neutralizing antibodies. The level of immune response you can measure is also related to the protection you can measure afterwards. And that's also an important experiment, because that means that we have an animal model now where we can test the vaccines before they go in humans and predict the potential of the immunogenicity and protection. And so those 2 experiments have been published in Science, and it gives now access to everybody to learn from that. And of course, we are doing our own work. And hopefully now mid-June, in 2 or 3 weeks from now, we will have the first real challenge experiment with our own vaccines. That's ongoing now. So lots of progress on getting to efficacy.
Dr. Stoffels, I know that several vaccines have already entered human trials and some will be very soon. So once a safe and successful vaccine comes out of trials, what happens next?
Well, the first step is animal models, and then over the summer, we are now planning the first week of September to start large-scale clinical trial. As Dr. McClellan was saying, we are preparing huge-scale clinical trials to go as fast as possible, first to phase 1, make the conclusions on what level. Do we use a single dose? We use a low dose, a high dose, or do we use 2 dosages? We have to confirm that in humans, and then we start a very large-scale clinical trial. That is all in full preparation, and that we talk about probably 30 to 100,000 people who need to be recruited in a clinical trial very quickly. lots of candidates. That is not going to be a problem, but we have to do it in a region where there is high transmission. So the preparation to do clinical trials, which we go around the country in the US, whether it's north, south, east or west, is a huge work to get that done. And then at the same time, preparing the active clinical trial material is all being done. All work together with the FDA. So we still predict that by the end of the year or early next year in the first quarter, we'll have efficacy studies, efficacy data, hopefully proving that it works. So we're looking forward to a great year of multi steps which we need to take, but we so far no hiccups, everything going well. Mm-hmm.
That is so promising to hear. We were talking to Dr. McClellan about developing this vaccine on an expedited time frame. But is there anything about this virus itself that gives you confidence that you can develop a vaccine so quickly? For example, how quickly is this virus mutating relative to other viruses?
Well, it doesn't seem to mutate that much or that significant. We have already seen a few mutations, and our scientists are continuously following that, and it doesn't influence the activity of the vaccine work we are doing. So it doesn't look like every second month there is like a new type of influenza, a new type of corona. That doesn't seem to be the case. And hopefully, if that's not the case, then we could mount long-term protection with one or two vaccines and maybe a booster after a few years or after 1 year. So that also needs to be studied. We know from Ebola that if we do a prime boost, we have now data up to 3-4 years that there is very good protection. We know from Zika, the vaccine studies we did, that with the low dose, high dose, you can have significantly longer term protection with a higher dose. So we have all those experiments which indicate on where we should look for going forward. So the clinical trial should show whether a single high dose works, whether we need a booster, yes or no, and then later on whether we need a booster longer term. But that is not unovercomable. That's a routine for us in vaccines to do. So all that is scripted out for us. Mm.
And Dr. Stoffels, I know HIV, for example, is a virus that mutates very quickly. And there still is no vaccine against HIV, but there are very effective treatments. Is it possible that we may get to a place where we just have effective treatments against COVID?
Well, it is possible. We hope that we can get to a vaccine because, of course, HIV is much more limited in spread than COVID. If you look at the number of HIV patients currently in the world, it's in the several tens of millions. It's not even in the hundreds of millions. So that is that's much more doable with the therapy. You could probably get to therapies for COVID, very specific therapies. First, there will be antibodies, which are in development now for the short term, treatment of severe disease or treatment of people with fever and symptomatic. But that is not that doable to do it on a large scale everywhere in the world. So small molecules, the old type of pills, need to be developed. That definitely will take several years to have good antiviral therapy for coronavirus. So there will be therapies, but hopefully we get to vaccines that we can eliminate the disease from the world.
Dr. Stoffels, we have a question from Nicole from Facebook, and she asks, is the vaccine tested against an inert saline placebo, or is it tested against another vaccine?
Well, that needs to still be determined. It's sometimes you have to use a control vaccine if the vaccine has some side effects, but most probably in our case we are going to test against placebo, and so the similar looking vaccine, but it will be placebo. And why do we need to do that? That shows the fastest that you have effect. So if you have a control group which gets a placebo and an active group which gets the vaccine, that gives probably in a few months, 3 to 6 months, you get the answer. And if you have that answer fast, it's so much better that people have comfort to know that placebo-controlled, this works, therefore we'll roll it out. It also gives a good view on the safety, so that you have people who are not getting the vaccine, and so it gives you also a very good insight on the safety profile. And that's why we very strongly, and the regulators also advocate a placebo-controlled study to prove that this works. Mm-mm.
Now, I have to ask you about recent news about how some kids are reacting to COVID. For a while, it was believed that kids who contracted the virus recovered pretty successfully, but now there are kids who are displaying Kawasaki-like symptoms as a result of COVID. What are your thoughts on this? And are vaccines being developed for kids?
Yes, well, first, the whole inflammation challenge of this virus is getting to certain people, is causing the severity of the disease. And we don't understand the pathology and the physiology of this whole mechanism yet. And that is something we have to learn. It's only by evaluating systematic in kids, in adults, in elderly, how this disease evolves, and do fundamental research, we'll know on the pathogenicity of the vaccine, of the virus, very well. Yes, we do develop a vaccine for kids. We don't know yet whether that will be useful or needed in the end, because the benefit risk in kids is there are not that many kids which show symptoms. But if you have a safe vaccine, we will definitely do it. And that's what we have done in Ebola. We have done from a few months, kids from a few months old to the elderly, people with immune symptoms, like immune problems, like HIV patients. And typically, it's what you have to do for this type of disease, to make sure you show that it's safe in all types of population, including in pregnant women.
And you have to conduct entirely separate trials for kids, is that right?
Yes, you have to conduct separate trials in different age brackets, from young to old, to show in every age bracket on young kids, adolescents, the immune effect. And also you have to, of course, look at the dose, what you use in these kids or in elderly. So it's a very extensive development program in the end to show safety and efficacy in all different populations. Mm-hmm.
I have a question from Rob from LinkedIn, who asks, is there a central resource that people who are willing to participate in clinical trials can contact?
Not yet, because it will be determined at the moment we know in what region, and at that moment there will definitely be systems to submit your names for potential participation in these studies. But at the moment not. I know there are on Facebook, and there are some large communities now putting themselves as a voluntary person. But we are not yet actively engaging with people yet, because we don't know where the vaccine studies will happen.
Dr. Stoffels, thank you so much for joining us. We look forward to talking to you more over the coming weeks. Thank you. I want to remind you all that we are live, and this is the Road to a Vaccine. Remember to keep submitting your questions in the comment section, and we will get them answered throughout the show if we can. Now, one of the things that COVID-19 has taught us is that we are undeniably a global society. My next guest has spent his career working to prevent global epidemics and is a longtime collaborator with the World Health Organization. I want to welcome Dr. Jonathan Quick, Managing Director of Response, Preparedness, and Prevention at the Rockefeller Center. Dr. Quick, thank you so much for joining us. Can you talk a little bit about the WHO's efforts toward a response to COVID, and what steps you think are the most important to slowing the spread of the disease?
Well, thank you, Lisa. It's good to be here. I think overall, the World Health Organization has performed admirably. I think Dr. Tedros and Dr. Mike Ryan, who led the effort, are people I've known for years and have a lot of respect for. What they have done is provide good pandemic communication. That's number one, is communication that is clear, that is truthful. You say what you know, what you don't know yet. You provide people with action points, what they can do, express empathy. Communication has been great, and that's number one. The second thing is that they've been actively monitoring the pandemic. Time matters so much. you have to know not just where it is, but where it's going. So we've gotten regular reports from the World Health Organization, and they've interpreted those. The other thing is thinking ahead of the virus. So while everyone was focused on Asia, they were already focusing on Africa, putting training resources in there, online training. And so I think those are the sorts of things that are really, really critical. And I think that has gone for an epidemic that is the biggest pandemic we've had in a century, and as big a hit economically as the Great Depression. That's a challenge, and I think they've met that challenge.
You're so right about the importance of communication. And on the one hand, there has been a lot of success in communicating really vital information, but also just given this age of social media and how quickly information travels, there is a lot of information out there that is inaccurate and conspiratorial. How do you think that is affecting people's perception of how lethal this virus actually is?
Well, I think it is a concern, and what you really want is consistent fact-based messaging. You want people to understand that this virus has only been with us for a few months. We're learning new things about it, so our best understanding will change, and that's what we have to base it on is our best understanding. I think right now, one of the things that is a very dangerous concept is this. I have a sense there's some magical thinking that because we've stayed indoors for 3 months, that the virus has changed somehow. It hasn't. The virus is exactly the same virus as it was in January, virtually the same in terms of its contagiousness, its deadliness. It's gotten to every populated area of the world in the U.S., and 90% of us, over 90%, 95%, haven't been infected, and so therefore we're still vulnerable. So I think it's vital as we open our workplaces to have strategies, as Dr. McClellan talked about, to keep open our workplaces and our communities.
But very cautiously.
I was going to say, one of the key things, if you think about how do we keep open the workplaces, number one is stopping transmission by personal protective behavior, which is what Dr. McClellan talked about. Number two is rapidly detecting and containing recurrent outbreaks. Hopefully we won't have a big wave, may in some places, but we're going to have wavelets. That's number two. And number three is advanced plans for outbreaks when they accelerate. So on that early detection of recurrences, that's where we need adequate testing. We need to move to a point where we can monitor the general population for the disease, for asymptomatic cases. We can monitor workplaces in the right area so that they know when something is getting out of control in a workplace, particularly the high-risk workplaces and high-risk workers like health workers and people that meet the public. And we need to have enough testing for those high-risk locations, communities like nursing homes, prisons, crowded urban populations. And so that is vital to keep us open.
Well, on that note, tell us about the Rockefeller Foundation's National COVID-19 Testing Action Plan. It starts with expanding testing in the U.S. from 1 million to 30 million per week within 6 months. Do you think testing is our key, our way out of the crisis, and will vulnerable populations be prioritized?
So testing is sort of the centerpiece of that stop transmission, early detection, and then rapid response. So yeah, it's the centerpiece of keeping us open. And so we get from the current 1 million tests a week to 3 million tests a week by basically ramping up the existing capacity, really unleashing that. The 3 million to 30 million is all of the new technologies we're hearing about and making sure the tests are reliable. But yes, absolutely, we need to get the right balance between testing the asymptomatic, those that when we pick up or without that, so that we catch that early, but also the high-risk communities. extra testing for those high-risk populations, as we were talking about.
Dr. Quick, we have a question from Aditya in New Delhi from LinkedIn, and she asks, how can we strike a balance between reopening the economy and social distancing measures? Do you have any advice for her on that?
Well, yeah, I think the whole issue is don't think you're going back to the old normal. Because the virus hasn't changed, we need to continue our personal protective habits. We need to wear masks when we're out. We need to keep that 6 feet, 3 meters. We need to have vigorous hand washing. We need to watch our surfaces. All of those behaviors, I mean, that is what has helped us flatten the curve or put it on a downward trend, bend the curve down, as some places, New York City has done that, Korea has done that. It's with that personal behavior.
Dr. Quick, in 2018, you published a book called The End of Epidemics, The Looming Threat to Humanity and How to Stop It, which seems pretty relevant today. What are some steps that we can take as a society to ensure that these types of events are mitigated? And what can we take from this crisis to better prepare us for the next?
So I think there are 4 key things. One is to build what I would call pandemic literacy, epidemic literacy, from schools on up to presidents and prime ministers and all. When you're in the middle of a crisis, your brain works differently. You know, you have got to have understood, and so that's one, pandemic literacy. The second is leadership. Leadership is so critical. It's just like a war. You need to get you need to get a battle plan, and you need to have consistent messaging around that. Investment. Just as an example, the problem we have here with test kits in the U.S. and some of the response, that didn't start in January or three years ago. It's been a 20-year process of defunding our public health system. In one period after the financial crash in 2008, we lost 45,000 health workers. So that's investment. And the third thing is innovation. One of the game-changing innovations in the end of epidemics was point-of-care testing. We haven't moved along the way we needed to. Had we moved that field of innovation farther sooner, we would have much better visibility on this epidemic. And again, time matters. Those tests matter to catch it early and stop it early.
We have a question from Luis from LinkedIn who asks, how could a new normal be possible if there's regrowth happening in various countries around the world? Great question. I mean, we are a global society. We move around. Is the idea of normalcy even possible if these outbreaks continue to rise in different parts of the world?
Well, first of all, the fear of that reality or concern about that reality ought to motivate all of us to practice those basic public health behaviors and respond when your province or state or district says cases are going up. We got to really hunker down for a little while. So no, it'll be a long time before we get back to something like normal, but some things probably won't go back. We're going to be cautious about touching, handshaking. Some of that may stay with us for a while.
Dr. Quick, thank you for that valuable information. And those 3 points that you made should be etched in our consciousness. Pandemic preparedness, leadership, and overall investment and preparedness. So hopefully this doesn't have to happen again, or we will at least be prepared to deal with it. Thank you so much, Dr. Quick, for those incredible insights. Now, every week, we like to highlight the human stories happening around the world, the people directly impacted by COVID, and the everyday heroes putting themselves on the line. And this week, I'm so excited for you to see this segment. We highlight a Miami artist who used her creativity to give thanks in a unique way.
When the pandemic hit, it was hard for many, especially for you guys. And as an artist, I felt obligated to contribute with something positive. It was a dream to be able to paint such monumental mural. This is just a little thank you from me. For a long time, you guys have gone unnoticed, but it's time to give you big thanks for all your hard work, for all your selfless soul. We really love you and we thank you. The idea of the mural was to create a comic book cover where all the superheroes are illustrated, because you are superheroes, all of you. The bright colors, it's all the bright colors that you guys carry inside. I have to be honest, when I was up there, I did get a little bit afraid. But then I thought, if these nurses are going to work and they're still putting their life at risk to save another person's life, to take care of another person that is sick, that gave me strength to say, I can do it too. This has been the most rewarding, the most beautiful, amazing project I ever done. So I want to thank you from my heart for everything you do, for everything that you are. You are our superheroes. Thank you.
Oh, that was so beautiful. Thank you to all doctors, nurses, healthcare workers, and all essential workers from all of us. Please keep submitting your questions at jnj.com/road-to-a-vaccine. We'll be answering more on Tuesday of next week on another live episode. And next week, we'll hear the harrowing story of a virologist who became a patient and is surviving COVID. I want to thank our guests today for joining us, and to all of you who are watching, thank you so much.